Yes.
Dr. Benson, we heard yesterday that there were 16 patients of the Belfast Centre who were infected with HIV, as well as a partner of a patient. And when you arrived, you said in your statement there were just 3 patients at the centre with HIV.
That's correct, yes.
Do you know whether any of the other patients had moved away from Belfast, or whether they'd all sadly passed away?
Regrettably, all patients had passed away by that time.
And as far as you're aware, were all of those people who were HIV positive also co-infected with hepatitis C?
I believe that the majority, whenever the Skipton Fund had been updated to go back to the pre-deceased patients and to see if we could avail of extending out the financial scheme to them, I had made endeavours for at least one of those patients who had pre-deceased to find evidence of hepatitis C infection, and we were not able to, through extensive trials, to be able to prove that. But of those that I am aware, yes, most were co-infected.
In terms of how HIV treatment is managed, can you tell us what the position was when you arrived at the centre?
Absolutely, yes. The position at the time of my arrival continues to be exactly the same as it is today. Dr. Segwa, who is a specialist in HIV medicine, was appointed, and as part of his appointment, the haemophilia patients were specified as part of his ongoing review and care. So Dr. Kwa will come across to the haemophilia service on a regular basis 2 to 3 times a year, and the patients are seen there with him, and all prescribing of the medication is managed by him and his department. The haemophilia service will attend to the patients with regards to their routine bloods ahead of Dr. Kwa's clinic to ensure a smooth transition of the patients, that he has all that information available at the time.
And how do you interact with him in ensuring that the treatment is holistic?
Yeah, I think that certainly from my perspective, it's always important to be up to date with regards to the treatment, because I think sometimes there may be unexpected side effects or things that the patients themselves will often signpost themselves to the haemophilia service. So I'll see Dr. Kwa whenever he comes across to the clinic, and we'll have a meeting or a refreshment with regards to how things have been for the patients beforehand, and then also a discussion afterwards. Notes are recorded in the patient's notes, so it is possible then for me to be able to go back at those at later stages needed.
Is there a difference then between what's provided for those patients who are seen by Dr. Kwa in the haemophilia clinic compared to what they would otherwise be provided with in terms of multidisciplinary care in an infectious diseases clinic or a GUM clinic?
I suppose the only model, unfortunately, that I'm aware of is the model within the Haemophilia Centre, which was the same even whenever I was a registrar. I don't know what the remit of an infectious diseases clinic would be.
And in relation to hepatitis C, can you recall what the numbers of patients were who were infected with hepatitis C at the centre when you arrived?
Yeah, I think that historically, I think as part of my statement that we had provided, that there was a record about 3 pages long that was found in the filing cabinet, which we sort of had extended to around 99 patients that we believed had hepatitis C PCR positive. At the time in 2008, there were approximately between 20 and 25 patients who remained hepatitis C PCR positive at that time. And as of today, the situation is there is 1 patient who remains hepatitis C PCR. They have been seen and assessed and offered their therapy, and they have currently taken the decision to wait.
And in relation to that list that you found when you arrived, if we can have a look at it, WITN 3082023. It's obviously all been redacted. There's nothing on this list which indicates when the testing took place. Was there anything?
Correct. That's my handwriting. So there are patients there that the PCR was negative and the genotype negative. So at that time point, it was negative. My annotation beside that is positive, is that subsequent test was positive.
And when you were trying to establish the situation with your patients, did you find any other documentation that gave you any indication of when testing took place and any dating for it?
No, as I said, the exercise that I had to take part in with regards to the review of the Skipton scheme for the predeceased, the only other resource that I was able to undertake was with the then head of the virology department, Dr. Peter Coyle, who I had asked to do a search through the laboratory system to ensure that if we searched under the source code using Dr. Main, as well as the Haemophilia Centre code, what records they may have of PCR testing, to try to get a more complete picture to support families with regards to their access to the enhanced scheme. But this was the most contemporaneous record that I had at that time with regards to the patients, as well as I met the patients themselves to review their own medical records and share with them their past experience, and those who were hepatitis C then negative.
Thank you, Shimit, that can come down. You've obviously annotated that note we just had up there with your own handwriting of people who were then positive. Does that suggest that you also retested people?
No. So historically, whenever I started and I went through that list, then I knew of those subsequent patients after having seen them or based on my own direct conversation with them that they were positive. In the last 13 years, one patient with regards to bleeding disorder has been tested as hepatitis C positive. He was a young gentleman who chose Northern Ireland as his new home, as he had travelled to us from Europe, and he had previously known to be hepatitis C positive.
And when you first met the patients on your arrival, what did you understand that the patients had been told about the risks of transmission to others? What was your sense when you were talking to them of what they knew?
Yeah, it's probably a little bit mixed, because probably whenever I met them all for the first time, it was for me to express to them the understanding and to refresh it and to update it. Clearly, as their new consultant, I became responsible with regards to their ongoing care. So I think with regards to most of it would have been more refreshing with regards to the risk of blood transmission, the low risk with regards to sexual transmission, but it was not a zero risk with regards to hepatitis C. And that would have been my routine stance with regards to the patients that I'd seen at the start. As to what they would have been informed historically, I would not have any knowledge of.
So you discussed the issues with patients afresh when you first met them. When you did that, did you get the sense that this was new to them or that this was something they'd heard before?
On reflection, it did not come across as being anything alarming. It did not appear to cause any undue distress to any of the patients whilst it had been explained to them, and whether or not that was because of how they had previously been consented or their basic awareness or just how it was delivered to them on that occasion.
Now, in terms of the provision of treatment for patients with hepatitis, Dr. Anderson in her statement has indicated that a weekly joint hepatology and haemophilia clinic was established from the 28th of June 2004, once Dr. McDougall had completed specialist training in hepatology. Was that what you found when you arrived at the centre, or had things changed?
That wasn't the picture at the centre whenever I arrived in 2008. In a true sense, a combined clinic will involve a hepatologist, a haemophilia doctor in the same room with the patient at the same time. At the stage in 2008, the vast majority of the patients who were hepatitis C negative continued at the haemophilia service, and those who were positive and had had previous standard first-line therapy in the form of pegylated interferon and ribavirin, and if they had not achieved a sustained virological remission, or if they're on a hepatoma surveillance programme or pending liver transplant, were all looked after at the Royal Victoria Hepatology Service. The cohort of patients that remained within the Belfast Centre, as had been the practice even as my time as a registrar from 2003, treatment was delivered on I described it as a shared care basis. We used the same protocols and the paperwork that the hepatology service would have done, and patients would have received their pegylated interferon and ribavirin and subsequent follow-up and blood tests through the haemophilia service with regards to their first-line treatment. So I had overseen the treatment from 2008 up to approximately 2014, 2015 of 10 courses of treatment involving pegylated interferon, of which, as you're aware, one patient was treated twice during that time frame. subsequent to 2016-17, whenever the NICE technology appraisals had come online with regards to the newer treatment, the remaining patients who were still hepatitis C PCR at the Belfast Centre were referred en masse altogether. And at that time, there were 13 patients, one of which had just started his treatment because was known to hepatology. There were further 2 patients who had chosen Northern Ireland as their home and who were hepatitis C positive, and that remained, I believe, 13 minus 3, 10 patients then referred over to hepatology automatically. Of those 10 patients or subsequent to it, treatment was offered to patients and discussed openly with them. What I did find at the time was a lot of patients saying that they were well, or a previous attempt at treatment using standard interferon had been provided to them and they had significant side effects from it, and at that time were not keen to take treatment. But reflective of the practice from 2008 to 2015, that treatment was constantly refreshed, reminded and updated to all patients at all occasions.
I just want to unpick that timeline a little bit more in detail. In relation to the initial period around when you arrived at the centre, if we could have a look at the UK HCDO audit from 2009, WITN 3082026. And if we turn to page 11, we can see about halfway down the page a paragraph starting 20 patients. A little bit further down. Thank you. 20 patients are HCV infected, 3 co-infected. Half are managed by Dr. McDougall at the Royal Victoria Hospital, whereas the others prefer to be managed on the unit. Unit staff directly coordinate HCV combination therapy for these patients with the full support of Dr. McDougall. If there are any concerns regarding the patients managed by the unit, they're referred back to the Royal Victoria. In that part of the audit, it suggests that the patients had a choice of whether they were managed by Dr. McDougall or whether they were managed on the unit. Is that right?
There's not so much a choice given to the patients other than the choice that they themselves had made. Largely, some patients, and even to this day, feel that the Royal Victoria Hospital has been responsible with regards to the infections that they acquired, and had found it very difficult to contemplate to be referred back there, often citing that that's where it all started. Other patients had had perhaps negative experience in the past with regards to a previous hepatologist, which again many had reflected, as well as I think that they felt more comfortable within the city hospital with the team that they already knew, knowing that the standard treatment protocols were there. I think one of the main advantages with regard to the haemophilia service was no delay in treatment. And so as and when patients were discussed and they were keen and open to receiving their treatment, information was provided to them and we could start them within a day of them having made that decision.
But I think in your earlier answer you indicated that there was a sort of clinical basis for who was dealt with by Dr. McDougall and who was dealt with within the clinic.
Yeah, so not a particular clinical basis. I think that we looked at the actual populations themselves. That was largely how the cohort of patients had split themselves across. So those with previous treatment who there were no other therapeutic option available to them, the vast majority of them had fallen into the Royal Victoria Hospital follow-up. And I think largely with regards to the follow-up or new treatments coming out. So whilst the haemophilia service had provided pegylated interferon and ribavirin in that follow-up, the newer therapies and the new education and information would have been made known through the hepatology service first, as well as through the haemophilia national and international meetings with regards to the newer treatments that came up subsequent.
Well, we'll come to the newer treatments in a moment. I just want to stay in this period where we're dealing with pegylated interferon. I'm still not clear, Dr. Benson, whether you're saying that the patients were given the option, whether the information was provided to them and they chose whether to be treated by Dr. McDougall or by the clinic, or whether you're saying that actually that was a discussion that you had with Dr. McDougall and you sort of divvied up the patients yourselves.
No, there was no discussion that I'd had with regards to dividing patients between which site that they were to require the treatment on it. So as and when the patients would come up, because ultimately all of the patients with regards to their bleeding disorder were reviewed at the clinic, then the treatment was discussed there. From my perspective, at no point had I referred anybody across to Dr. McDougall and his team for the primary purpose of treatment with pegylated interferon and ribavirin.
In terms of the support of Dr. McDougall for that cohort of patients who were treated within the clinic, what did that constitute? How did that work?
Yeah. So we have a very open communication channel even today with regards to the hepatology service. So with regards to the patients, the paperwork that had been provided and worked on from the service having taken over the treatment, so prior to my appointment, in how pegylated interferon is prescribed and followed up and discussed. So all patients are discussed, and there's a hepatitis C database that was maintained by the hepatology service. We had regular meetings with Dr. McDougall with regards to patients and patient progress, and any concern with regards to any of the blood tests that any of the patients had presented with, or that the patients wished to have any further discussions, then we would have had that discussion directly with Dr. McDougall.
And in those early years, did you explore re-establishing a joint clinic with a hepatologist?
I had felt that at the time that the service itself had started off, as my understanding had been, as a joint service, and for whatever reason, the full history of which is not known to me, that the combined clinic service had stopped or had felt to be that an alternative way was better or sought, and that's the service that was there in 2008.
But did you take any steps to consider or explore the possibility of bringing that into the haemophilia clinic as a joint clinic?
Yeah, we had those discussions with regards to it. I think with regard the communication and everything else seemed to be working okay, and there was no issues with regards to either from the patients or Dr. McDougall or the clinical or nursing staff with it. But we had those regular discussions that it had never really come out of it to think that it needed to be re-established.
What information and advice were you able to provide to patients about lifestyle factors such as diet and alcohol in the management of their hepatitis C?
Yeah, so it was a very clear challenge that we had from 2008 with regards to some of the men, particularly with regards to alcohol. So in discussions with Dr. McDougall and sharing that along with the patients, we appreciated the fact that with pegylated interferon and ribavirin, the success rate is lower for hepatitis C eradication, but also the side effects are much more significant. One of the other challenges that we had previously alluded to was really a disengagement from the general review protocol from the clinic, and patients really coming and being reviewed and being adequately followed up. So from our perspective, at each opportunity that I had with regards to patients face-to-face was to try to be open, discuss the availability with regards to the treatment, and highlight really the long-term outcomes that maintaining hepatitis C positivity was there. Many of the patients would have noted it and taken it on board. They, as I'd said previously, would have felt well, and they wouldn't have felt an advantage in the shorter term with regards to taking their treatment. The discussion was open. It wasn't given as a coercion. I was always very minded to try to make sure that I didn't exacerbate the disengagement any further with regards to people then thinking that every time they come up to the clinic that all I was going to do was to try to ensure that they took their hepatitis C treatment. But certainly with regards to alcohol was an issue. What we would have done would be to try to signpost patients with regards to their alcohol intake and to see if there was anything extra that we could do to help to support them with that. Several of them were very receptive to that, both seeking their own family support, and I remember several of them coming to the clinic with either their children or with their sisters in order to help them through a period of abstinence to allow them to be able to take their treatment. It was clearly very difficult for many of them, and the success rate was good with regards to the abstinence, but I think that in the longer term, they really did struggle both with regards to their mental health and with regards to their family relationships.
And in that regard, did you consider referring patients on? Was there any way you could refer patients on for additional support in that?
Yes, no, absolutely. And it would be with regards to the support either through primary care or through addiction counselling. At that time, I'd undertaken some training or sort of course with, not really a course, but with regards to motivational interviewing. I think it's all well and good that I can see a challenge or a problem with the patient, but if the patient can't see that problem themselves, so I was trying to tackle it with going through in a motivational and positive way for them. And we do the same with regards to smoking and obesity, but it was a particular challenge, as it is for a Northern Ireland population in general, with regards to alcohol intake.
And when you were discussing the advice around diet and particularly, as you say, alcohol, was it your sense, was it your impression that this advice was new to the patients or something that they had been informed about before?
I think on most of the occasions it certainly come across as something that they had been aware of. I think perhaps less so diet. I think at that time in 2008 and moving forward with regards to obesity, it wasn't such a significant occurrence or issue that perhaps the centre will face with their patients today. But at that stage, definitely with regards to alcohol and the exacerbation with the hepatitis C virus, that cirrhosis was more of a significant and an accelerant challenge for them.
You just said that you oversaw the treatment, the giving of 10 courses of pegylated interferon and ribavirin. What information did you give patients about the side effects of that treatment before they started it?
So there were drug-specific leaflets that had been produced and provided, and the patients were given those in relation to their ribavirin capsules and also their pegylated interferon. I think from first-hand knowledge as a registrar going through the service and seeing the patients on the treatment, mood and is a common challenge that the patients will face, and the advice with regards to your prophylactic antidepressant being advised. Generally, that was my preferred route for patients, given the time frame that's required for an antidepressant to get into the system before it starts to work, rather than reviewing them after 2 to 4 weeks and then finding that they're already being challenged with regards to their mood at that stage. So I think that the side effects of mood change and lability in mood, as well as sort of constant flu-like feeling, would generally tend to be the commoner ones. The other one, obviously, looking after young men, was the impact of the ribavirin and teratogenicity with regards to having children, and indeed on one occasion of those patients who were treated at the time for treatment was selected at a time that his wife was pregnant for him to be able to take that treatment.
In addition to prophylactic antidepressant medication, since you didn't have an embedded psychologist within the clinic, was there any scope for providing any more structured therapeutic intervention for those who were struggling with low mood or depression?
Yeah, so we had access to the haematology social worker with regards to support in that service, as well as signposting through their own GP to see if there's anything more convenient or local to them. I generally found that a lot of it was acknowledging the fact of the side effects that they had up front, acknowledging what they were going through and what they were facing, and the challenges and the struggles of it. I think certainly those men who had previous history treatment with regards to standard interferon were much more receptive with regards to the discussions about the antidepressant, and being minded of the side effects that they had previously suffered from.
Now, you've indicated that once the newer non-interferon-based therapies became available, the mode of treatment changed. I think you gave the date as 2016. Is that right?
I think with regards to the last course of the pegylated interferon was 2014, 2015. The discussions then at that stage with the hepatology service were in line with regards to the non-pegylated interferon-based treatment, in line with the NICE technology appraisal. So as you're aware, some of those will have stipulated early on that you had to have a previous course or a trial of pegylated interferon and ribavirin and be resistant to it before you became eligible for the next line or the second line. So I was very much aware around about 2016, 2017 of letters and further to the discussions with the hepatology team and Dr. McDougall. We had a discussion, given the fact of the previous provision of treatment through the haemophilia service, whether or not that would be something that would be considered. Neither of us felt that that would have been appropriate based on the level of knowledge with regards to the newer drugs and the monitoring. There had been enhancement to the hepatitis C service with regards to additional nurse specialists that had been provided there. So at that stage, with regards to the newer treatments, then patients started to receive them, with regards to those who had known cirrhosis or challenges or derangement in the liver function tests, and then at which stage then the patients that remained at the haemophilia service were then referred altogether.
Are you aware of there having been any delay in Northern Ireland in accessing those newer drugs compared to the rest of the UK?
None that I'm aware of, and I certainly think that with the discussions with Dr. McDougall at that stage, that the service itself had prescribed many of the medications from the technology appraisal from NICE in advance of the NICE having been published.
Now, in terms of current care, you've indicated that the hepatology service manage patients who've had a liver transplant.
That's correct.
But the transplants themselves, we've heard, take place over in London.
That's correct.
And presumably you're not involved in any way in any of the assessment of patients for referral to King's?
I would be involved with regards to sharing of the information of the bleeding disorder, the clotting factor concentrate that the patient would have been receiving, and any past complications such as inhibitors or something that the haematology service at King's would require. So as part of the referral, there would be a haemophilia summary that I would write and provide for those patients.
In terms of patients who've developed cirrhosis, you've indicated they're also managed under the hepatology service. Do you know what ongoing monitoring and care is provided through that service?
So the hepatoma surveillance service is a 6-monthly ultrasound scan, which is organised through the hepatology service. And on the day of the ultrasound scan being performed, a serum alpha-fetoprotein is also undertaken for those patients. They continue to have their haemophilia and other bloods checked routinely at our own outpatient clinic, but the hepatoma surveillance programme is the ultrasound scan and that blood test.
And how do you coordinate between the haemophilia team and the hepatoma surveillance clinic?
So the hepatoma surveillance clinic is run on an automatic 6-monthly basis, and the hepatologist will get those results and if necessary, book an additional scan or review of the patient should the ultrasound scan show any change or anything different from previously. From the haemophilia service perspective, the patients continue to be monitored at their 6-monthly or annual basis as they would do normally for their underlying bleeding disorder.
And are you aware of any patients, any of your patients who are under that hepatoma surveillance programme, raising concerns with you about their care? Have you had any of those sorts of conversations where patients have come back and said, we're concerned?
About care with regards to their hepatology care, or with regards to their haemophilia care?
In relation to their hepatology care, and particularly in relation to access to FibroScans.
Yeah, so FibroScan is something that more recently has become part of the routine nature of the hepatology service, and is largely utilised for patients for the hepatitis C treatment. As far as I'm made aware, it helps to differentiate between 12 weeks or 24 weeks. Patients have raised with me, those who have undertaken their hepatitis C treatment, and as I've said, there's only one patient who remains hepatitis C positive. Patients over the last year or two have contacted me and accessed and queried whether or not they can get a FibroScan. We have discussed that with the hepatology service, and based on those requests, that has been facilitated. But from hepatology perspective, it would not be a routine follow-up scan for patients at this stage.
I just want to clarify as between two different groups of patients. Firstly, the patients who do have cirrhosis, do they have a routine FibroScan? So I'm afraid I think Dr. Benson's frozen again. Hopefully in a couple of minutes he'll return.
Yeah, we are.
Oh, there we go.
We're back. Ask the question again.
Thank you, sir. I just want to clarify between two different groups of patients. Firstly, the patients who do have cirrhosis. Are you aware of whether they do have a routine FibroScan?
With the diagnosis of cirrhosis, a routine FibroScan has already confirmed the cirrhosis. So those patients who are on the hepatoma surveillance get a 6-monthly ultrasound scan, as I am aware.
In relation to the patients who are now PCR negative, but haven't developed cirrhosis, how is their condition managed and monitored?
Their condition is monitored with regards to their haemophilia routine bloods that we would routinely check with them, and monitoring and follow through with regards to liver function tests.
Is there any?
As per the hepatology service, there would be no routine need or service in place with regards to FibroScanning patients who are now hepatitis C PCR negative.
I think you said earlier, though, that if a patient raised particular concerns with you, that they were concerned and worried, that in some situations you have then arranged for them to have a FibroScan.
I haven't arranged, I've signposted them to the hepatology service, and then they can have the indications and needs as that discussed with them, and then to undergo the FibroScan with them.
And do you know whether patients have been able to access that through the hepatology service? Or
yes.
whether it... Sorry.
Yes, there's been no issue with regards to any of the patients that have been referred at their own request through me to the hepatology team. They are very happy and willing and very capable of undertaking the test and have done.
In relation to the patients who have had treatment under the Haemophilia clinic previously, so in the pegylated interferon ribavirin times, is there a group of patients who've never had a FibroScan because they were cared for under the Haemophilia centre for their treatment and they're now PCR negative? Is there a cohort of patients who've not had that access?
Yes, but it's not because they've been looked after by the Haemophilia service to have their treatment. It's because historically they've had their treatment prior to the availability of a FibroScan, which has only been, I think, the last 3 to 5 years. So there have been over half of the patients have had standard treatment 10, 15 years ago.
And so in terms of their ongoing monitoring, that's provided through liver function tests?
Yes, and full blood count to check the platelet count.
The inquiry's heard evidence that many people in that situation remain very anxious about the condition of their liver and a very real fear of the hepatitis returning. How do you address those concerns within the clinic?
I think for those patients, you're quite right, it is a real concern for them. I think from our perspective, it's to go through the blood results that they've had and to show them where they've been with regards to the test and the reassurance that those tests are within the normal range and there's no signal or no concern that is being highlighted from them.
And going back to what we were discussing a moment ago, if they asked you for a FibroScan to check, you would refer them to hepatology?
Yes, if a FibroScan came up, but equally if their level of alarm or concern is significant, I wouldn't wait for a patient to ask me to access a FibroScan. We would be in a position to be able to refer on and have the discussion with hepatology with regards to their access to it, and equally for them to provide the same reassurance that we are doing.
And are you aware of any gatekeeping done by hepatology which would require particular liver function test results before giving a FibroScan, or is there a sense of enabling patients to have a FibroScan in these circumstances, even if perhaps the liver function tests are not indicating there was a need?
Yeah, there's absolutely no gatekeeping whatsoever. And if we feel that there would be a great amount of positivity or reassurance provided to a patient or to their family, the hepatology team are more than willing and able and have done and provided the scan, and some patients on multiple occasions for reassurance.
The inquiry's also heard evidence from a number of witnesses who, although they've been treated for hepatitis C and they're PCR negative, have continued to suffer from very considerable ongoing symptoms and difficulties. How is that managed within the centre?
Yeah, so I think with the multi-professional team that we have, it's to look at the specific symptoms. So I'm aware of quite a number of individuals, as you have also highlighted, symptoms such as fatigue and ongoing joint pain and concentration. So the long-term sort of multi-systemic effects of hepatitis C and just bearing those in mind and taking them forward. So be that through support with regard to their joints, social work support with regards to anything additional that they can be provided with, occupational therapy, counselling in relation to talking issues through are all available with regards to the patients.
Now, I want to move on to Vcjd. You said in your earlier evidence that Vcjd notification was one of the issues that patients highlighted in the survey before you arrived in Belfast. Can you tell us a little more of what the themes of that were? Yes,
no, absolutely. It's quite distressing I know with regards to the letters, I think that for those, some men kind of feeling what's next, and it had really established an element of mistrust, I think, with regards to all that they had already come through, and then variant CJD being added to that with regards to your risk. I think the challenge of not having a blood test for it was difficult for many to just be told that, you know, as a public health issue or risk that you are being told that you're at risk. And for many, this felt really very difficult, and a lot of, I think, general lack of understanding with regards to what the risk labelling actually meant to them, and what could happen and what can't happen, and various delays and concerns with regard to them trying to access medical care, now with the label there with it. I suppose some of them had been written out to twice as well, so some of them had really felt that this was reminding them of a reminder or of a letter was very difficult. And in some of the records, there are handwritten letters from patients to the interim director at that stage of the second write out to Frank Jones, of patients really very clearly spelling out their absolute anger with regards to the receipt of a letter, that for many they weren't aware of that it was coming.
And then in relation to your time at the centre in 2009, if we can look at the document GGCL 40.222_001, please, Sumik. We can see that these are meeting minutes from March 2009 of the Scotland and Northern Ireland Haemophilia Directors Group. And if we go down to page 2, paragraph 4D, under the heading VCJD notification exercise. Thank you. We can see that concerns were expressed about the notification process, and towards the end of that paragraph, GB reported concerns, which I believe is you, Dr. Benson. GB reported concerns that he was informed by a patient and a WFH representative who knew of the new VCJD information before we as haemophilia directors did, and that his colleagues in blood transfusion seemed to have known for 2 months prior. What can you tell us about this?
Yeah, so I think not that long before this meeting took place, one of our patients who was very into the World Federation of Haemophilia had visited the centre, and actually on that occasion had brought with him the then president of the World Federation of Haemophilia, Mark Skinner, to visit the centre and to have a look around and just for a general chat. And it came out as part of that discussion with regards to an event or a patient who had a mild haemophilia, if I can recollect the subtype that he had well enough, and at post-mortem prions were found within the patient's spleen. So after he had left, I thought it was a little bit unusual that they were made aware of that, and I'd contacted our blood transfusion service colleagues again just to try to gauge from their perspective what their understanding, or if they had any particular knowledge. And again, as reflected in the minutes, that they also had it. So it reflects the case and the letter in relation to the patient with haemophilia. He had prions in the spleen but did not have variant CJD.
And did that delayed knowledge for you cause particular difficulties?
I think sometimes it's just that slight issue with regards to a patient raising their concern or sharing it with you, and then being a little bit, unable to provide that additional support or that level of understanding, or trying to put the issue into context with what they were discussing. So a patient with haemophilia with prion was not with variant CJD, but that it was noted in a patient's spleen, and as such it was quite a different situation from what was being shared.
In your statement, you say that the Trust established a VCJD group to manage and identify patients at risk ahead of surgical procedures. Can you tell us how the group went about managing your patients who had been identified as at risk when they required something like an endoscopy? What processes were put in place?
Yeah, so the World Health Organization had updated their pre-surgical checklist and had placed in variant CJD risk assessment ahead of procedures. So a group was set up in the trust, and I was invited to go along with regards to probably having the largest cohort of patients who are placed under a public health risk with regards to variant CJD, and to see from the trust perspective how they were working out a risk assessment form in order to ensure that patients were appropriately being screened and assessed ahead of their surgical procedures.
Now, it's understood that in relation to the 2009 notification, you took the decision not to issue letters to patients.
The trust took the decision not to issue letters. The letters came in through the Public Health Agency to the Medical Director of Belfast Trust. At that stage, and I had a meeting along with the team and the Medical Director, and we reflected on the letter that had been drafted and came in through the Public Health Agency, and ultimately the letter highlighted the fact that the patient with haemophilia had a prion presence in a spleen biopsy, or a spleen at the time of postmortem, but had concluded to inform all of the patients that this did not change your risk based on what you had previously been told. So the Medical Director, along with ourselves, agreed that the letter to go out, given the fact that it did not change risk, was appropriate.
Can you tell us anything about the discussions you've had with patients around this time about VCJD, either in relation to the 2009 notification, which you didn't send the trust didn't send the letters out, or in relation to how it's discussed when they have a surgical procedure coming up?
Yeah, so part of the original letters that went out were also copied to GPs. So if a GP happens to refer a patient into another hospital for a procedure, it falls part of the medical history record from the GP to ensure that it's highlighted to all individuals or surgeons or endoscopists who may be looking after patients. In general, we try to do our best to ensure that we centralise any surgical procedures or biopsies within the Belfast Trust itself, where there is a cohort of individuals who are very well experienced with regards to what is required, but equally that a delay in a procedure is not acceptable purely based on a variant CJD risk. So the patients will always go through their own standard risk assessment. They'll be asked the questions from the nurse doing the assessment for the procedure, and it would also form part of our discussion with the team. So, for example, patients who will be getting joint replacement surgery, that whilst the patient themselves may notify the fact they're at a variant CJD risk, that actually the surgery itself does not present any challenge with regards to the instrumentation being used.
But in terms of your discussions with patients, how is that dealt with?
Well, we would recap with regards to any surgical procedure that they would need to get done, that they're aware. We don't do the risk assessment ahead of any procedure, so that's done centrally with the individuals doing the surgery or the biopsy or whatever it is that's being done. But we would intervene with regards to clarity for the patient that it's either an at-risk procedure or not, and also with regards to the person doing it, so that they're aware that instrumentation should be disposed of afterwards, or if in doubt, quarantined in the likes of an emergency procedure until we can clarify it the next day.
As you said earlier in your evidence, there are a number of patients for whom the VCJD notification has caused considerable anxiety and concern. Is there any formal counselling or psychological support that's been put in place to assist with that? Or is it simply the question of the open access to the psychological service?
Yeah, so if I remember from yesterday's evidence as had been presented, Dr. Julia Anderson had touched on the initial write-out exercise with regards to variant CJD, had highlighted the counselling that had been made available and set aside at that time, and that at the time of the first write-out that actually no patient had availed of what was made available at that time. With regards to the second write-out, I was not there at the time to be able to provide any assessment as what's there. The system, as you've highlighted, that if the patient has any particular concerns or anxieties or worries, then we are able to signpost them appropriately. Either within the team themselves, if they're happy with that, for either myself or a member of the nursing team, or their social worker, if there's any challenge, or indeed, as you're aware, more recently on to the dedicated psychology team.
Now, before I move on to look at medical records, in your witness statement, when you talk about patients seeking records recently, you've referred to the hospital trust having an inquiry team made up of senior management. Has it been any part of the inquiry team's work or remit to meet with those who were infected or affected as a relative?
Yes, they have. And they have taken direction from the local patient support group, or Haemophilia NI, and they have met with senior members of that team. The inquiry team itself, with your colleagues, have also met with the team. They have had a tour of where the notes are kept and recorded. They're aware of the methods of the search in trying to locate and to find all records, and that has been shared. But yes, the medical records team and senior management have met with representatives of the infected and affected.
Then I just want to deal with some of the questions around medical records. Sumit, could we have WITN 4027001? This is Dr. Anderson's statement to the inquiry, and there are two passages I want to look at with you, one of which we saw yesterday, but I will put it on the screen in case people weren't watching yesterday. Paragraph 6.8.23. It's on page 16 of the statement. This is the passage that we looked at yesterday, sir, but I will put it on the screen just for completeness' sake. Medical records were handwritten and kept meticulously. There was excellent administrative and secretarial support, and it followed that the filing was good, with the medical records kept within dividers in the case notes, and any written results were filed in separate sections. That's what Dr. Anderson records as what she found when she arrived. And if we go on to page 127 of her statement, paragraph 67.1, and this deals 67.1a, this deals with when the centre moved. She says, at the Belfast Centre, I moved all the patient archive records and all relevant blood bank records from the Department of Haematology, Royal Victoria Hospital, to the Haemophilia and Thrombosis Centre, Bridgewater Suite, Belfast City Hospital, at the time of the centre's relocation in September 2001. The records were kept in a locked room within the Haemophilia Centre in the Bridgewater Suite. Old records were kept, to the best of my recollection, at Musgrave Park Hospital Records Department, and there were strict instructions that old records must never be discarded, owing to the likelihood of patients wishing to review their case records in the years to come. In terms of when you arrived at the centre, Dr. Benson, where were records of current patients kept?
So the current active records with regards to patients, as Dr. Anderson has described, are maintained within the admin room within the Haemophilia Centre. So they are filed from A to Z for all of the patients with all disorders that are looked after by the team. At that time then, whenever volumes became needing to be refreshed, if notes were getting a bit busy, then old volumes were then placed within the filing system, haematology, the haematology secretary corridor with the other consultants on a separate run for the haemophilia patient notes. But active notes were maintained as described in the centre.
And in terms of old records, were you aware of any being held at the Musgrave Park Hospital Records Department?
I think with regards to the location of such records, they would not be anything that I would have been aware of as to exactly where they would have been. I know historical records can sometimes be stored at Erskine House, which is where the old records may be, but there are many places, as I have learnt through the inquiry and searching for notes and records, as to where patients' records may be stored.
And when you arrived and came to treat patients and looked at the notes, were you aware of any gaps in the records or information that you would expect to be in them? Were you aware of any gaps in that?
No, there were no gaps that I had whenever I was trying to find the relevant information regarding the patient who was sitting in front of me. as I was familiarising myself with regards to their history. As Dr. Anderson has highlighted, they were meticulous note-keeping with regards to the history of the care the patient had. The vast majority of them had a very useful summary front sheet which highlighted previous doses and treatments or surgical challenges that they may have faced in the past.
Now, the inquiry is aware that you've had quite considerable involvement in trying to help patients obtain records. The inquiry's heard evidence from some patients and relatives who've described difficulties in accessing records and some who've described your help in accessing records. Can you tell us your involvement in this? What have you been doing?
Yeah, so the Trust have been tireless with regards to trying to locate records and to support patients as far as what they can be based on the records and the destruction of records policies. The hospital itself has undergone many reviews with regards to health and social care trusts and boards and various different policies, and I know that Ms. Richards highlighted many of those yesterday with Mrs. Leonard's statement with regards to record keeping. For the vast majority, at the start we'd had any subject access requests that were to come in through me and be signed out immediately to go and to see what records could be found. But really it was I think largely a learning process with regards to finding the records. The vast majority of them were to be easily located in the first search of it. And then we became apparent that the searches were repeated largely because of filing systems. So if I were to perhaps use my own name as an example as being Gary Michael Benson, some patients had their records filed because they were called Michael. So it was filed under Michael Benson, but the birth certificate name was Gary. And we also found issues that if Gary Benson was searched for and there was a space between Gary and Benson, that was a set of records, but if there was no space between Gary and Benson and it was all one word, that was filed separately. So in repeating the exercise of trying to find patients either by their birth name or by their called name, or whether there was a dash or a forward slash, the medical record team were really, quite frankly, amazing. And I think that's where some of the initial learning that we derived from the process was that sometimes the tendency had been dried out to go, we have had a look and we can't find anything. And I think often, based on the wording used, that it should have been a bit clearer by going, in our first search we haven't found anything, we will repeat it again and we will look elsewhere and we will seek elsewhere. And I think with regards to the policies of destruction and everything that's already been provided, that the vast majority of the medical records that are available to be found have been found, and they're all stored separately in a separate part of our hospital and are not touched out with patients requesting access to them.
In relation to information on patients that have been fed back to the UK HCDO, you've said that in the records there was evidence of past consent to that. Can you tell us what you identified in the records and from what date?
Yeah. So a lot of it will probably cross-reference with Dr. Anderson's statement with regards to the meticulousness with regards to how Dr. Anderson had undertaken her work. UK CDO had performed a question and answer session with regards to the information on the database and had put that into a leaflet. So the record that I refer to is a historical leaflet filed in a Polly pocket in the front of some of the notes with Dr. Anderson's signature on it with regard to the explanation for the patients at that time about data and what was being shared or what their data was being used for and being shared.
And again,
been updated by myself with regards to the boys or girls during transition or transfer of care to refresh their information. Often parents may have been informed during the childhood, but again, with regards to the custodian of data for the patients themselves, is to remind them of that too.
And again, when you were undertaking that exercise of checking whether there had been whether there was evidence of past consent, did you face a situation where a particular bundle of medical records, one file was missing, or you had some of the files of medical records from the past but not all of them?
So the trawl of the medical records as part of the inquiry, I did not on any occasion read or look into any of the information, as I didn't have any consent to do that. So as and when the records were pulled and copied and provided to the patients as and when they were found. The only information that I have with regards to historical use through records is again through the Skipton access and the review of that material. I was aware that there were several folders within a filing cabinet in my office, which dated back quite a considerable period of time and reflected on some of the patients, the vast majority of whom had been HIV positive. So the use of those files were used to support the families with regards to their access to the update of Skipton. All the content of the filing cabinets at the outset of the inquiry were automatically copied and uploaded to egress for the inquiry's information. Subject to that, and a time afterwards, I was then asked as part of the trust to go through and to find additional information, particularly for those families who may have accessed and requested letters or things pertaining to the individual. So I went through all of those documents, and anywhere where a patient's name was noted, and that was written down and that was provided to those families also.
So just to be clear, in relation to the UK HCDO consent, you didn't do
no.
you didn't do any look back exercise to check, and you didn't identify any missing records there.
The active notes the patients have, they were filed in the polly pocket at the front. So sorry.
And just picking up on your answer there in relation to separate files that were in locked filing cabinets in your office, from what period do you think they probably dated from?
With regard to the uploaded egress, there are miscellaneous discharge letters, and I think that the earliest has been, if I were to pick a date in the 1960s, there could be a very early 1963 letter. So they are a mixed bag and hodgepodge of various things, some of which were put into files relevant to an individual patient, and some were just, I'm not quite sure why they were there.
You've mentioned the exercise in relation to the Skipton Fund that you undertook, and we're going to come back to that in just one moment. But before we do, can you tell us what involvement you've had during your time at the centre in telling patients about the existence of the various trusts and schemes?
Yeah, so with regards to the vast majority of all patients whenever I had started, the knowledge with regards to Claxton or with regards to the HIV groups in Skipton were already very well established. As I'd already alluded to, the polly pocket at the front of the notes with the UK CDO information leaflet, equally the Part 1 or Part 2 completed documentation with regards to Skipton applications were also filed and maintained within the patient's records. So all patients who would have had availability at that time to access those schemes, I understood that they had already done so.
And you've spoken a moment ago about the situation that arose when the Skipton Fund extended the provision to relatives of those who died before August 2003. Can you tell us how you went about seeking to identify relatives who should be informed?
Yes, I find that whole thing quite difficult, I think, with regards to largely the communication and the face-to-face meetings with families, from whom we have no ongoing contact or communication because no other family member attends us. The group were largely identified, as you've highlighted, through the list of hepatitis C positive patients that was in the filing cabinet. So I was able to utilise that list and to see and cross-check with regards to death histories of those individuals before Skipton came into place, as well as contacting the virology laboratory to see if they were able to provide a simple search with regards to hepatitis C PCR testing and what was positive and what was coded at that time to, I think I ran the code with regards to Dr. Main as well as Dr. Jones, and to see if there was any additional information that we had. The first set point...
Oh, we're stuck, I'm afraid.
We're stuck.
That we had the information.
I'm sorry.
Just pause, because we lost you. We lost you at the point where you said, with regards to Dr. Main as well as Dr. Jones, and to see if there's any additional information that we had. And then there was a freeze.
Okay, sorry. So that allowed me then to work out who may still be under active review or any other family members. And we discussed it at that time with the team. So the team at that time had been the established team that had been there for some time, and had also worked along with Dr. Main and Dr. Anderson during that time frame. So their information was very helpful and supportive of it. So for those patients that we had active still on our list, should it be a grandson or a daughter, those patients were contacted in an appropriate way with regards to the change in the skipton, and to say that we believed, or that I believed, that there was information that we would have that we would be able to help them and to support them in their application for their Part 1. The challenge, though, with regards to anything beyond the Part 1, particularly for Part 2 application, is paperwork in order to prove evidence. And the commonest way that this was only ever applicable or available is if it was noted actually on the death certificate. And medical records for those patients were not always available, or were not available, unless there happened to be miscellaneous letters within the filing cabinet pertaining to those individuals. So we approached families and we encouraged them to come up. It was really very difficult. I think that I remember one occasion a mother coming up in relation to her son, and I found the consultation challenging in talking to her about her son, because he was only a few years older than what I was. And I just kind of felt that no matter what the compensation or whatever the money may have been, what this woman wanted was her son. And for me to come 20 years after he had died, it was just not good. Sorry. And she's never left me. So as far as possible, we went through it. It was a very difficult time for many families, and I just felt to sit there in front of these exceptionally dignified people, and for me to offer them a bit of paper to sign, and that I'd sign my bit, and that they would get a check. It was just awful. So it was really a pivotal moment, I think, for me professionally. But they were so good. You know, I got a thank you letter, or they thanked me afterwards for absolutely nothing. Absolutely nothing. Just total waste. Sorry.
No, take your time.
Take a moment. There is absolutely nothing to apologise for. Just take a moment.
Okay. So the information then was used, and we tried to encourage as many. I think that over the years, even I think up to about 2 years ago, I think I came in contact with another family, and we were able to have that information for them. So there have been, I still think, from my understanding, still at least one other individual family, from my perspective, I was very keen to meet and to support them in relation to that exercise. But that's been something that perhaps the grandson has just transitioned across to us, and then suddenly the discussion with the mom, and then discovering her maiden name, and then going, oh, you know, I have somebody's name on my list. Do you know this man? And then it turns out to have been her father. So, yes, sorry.
You've answered my next question, Dr. Benson, of whether you felt you'd managed to identify the families of all of those who had died, but clearly you still think there is at least one more family who you haven't had contact with.
Yes, I think even, you know, the detective work with there was one mum that we got in contact with her because rather randomly her sister had been referred for another reason into the Haemophilia Centre, and then she was able to share about her nephew having been a patient, and then that's how we found the mum, and she came up.
The inquiry heard a lot of evidence when we were over in Northern Ireland of the stigma and the secrecy that was involved in patients having hepatitis C. Before you contacted family members, did you give any consideration to whether families had in fact ever been told about the patient's infection, or whether that had been kept from them? And if so, how did you deal with that? Yeah,
I think that the vast majority were aware. I think that how families shared that outwardly, as you have highlighted and as was testimony with a lot of our patient stories 2 years ago whenever you visited us, is that how families shared it. Families were aware within themselves and within their own home, but on occasions they were less so with their extended family member. At the time of trying to identify the vast majority of the patients, I also had my colleagues in the centre who were there at the time with regards to the death of the individuals and those men and women. So they were able to highlight that also to me with regards to what was known.
I want to move on, Dr. Benson, to pharmaceutical companies. You've told us in your statement that pharmaceutical companies provide centre staff with updates on their products, but have no influence locally over decisions given the central tendering. Has the centre received any funding from pharmaceutical companies in your time there?
Funding has been made available through several of the family days. So the Roald Dahl Foundation, as I've highlighted for the initial one, had sponsored that. And with regards to the second day, each of the factory companies had provided a nominal sum of money of £500 towards the support of it. Of that day, the vast majority of the remainder of the day was paid through the Haemophilia Centre Fund itself.
And have clinicians received funding for conferences or travel or anything like that?
I think with regards to support for educational meetings, they have been made available, and they would be things that from time to time that it may be suitable. As a single-handed clinician, I don't often have such availability of time with regards to them, but yes, as part of an educational service we have been.
And what do you do personally, or what do you do at the centre to guard against any risk that companies contributing to the centre's work, that they don't influence the decisions you make about prescribing products?
So part of my additional role is on the Drugs and Therapeutics Committee of the Trust, and as part of that there's a declaration of conflict of interests, as to there is also for UK HCDO, also for taking part in the CMU accreditation with regards to the tender process, so that there would be a standard way that we would do that. The Trust itself has its own policy with regards to accepting gifts, both from patients and relatives, but also from external bodies, and the Trust has a policy with regards to pharmaceutical companies and their visitation on site and their interaction with us as healthcare professionals.
And you've noted in your statement that you've participated in research that was sponsored by pharmaceutical companies in relation to new product development. What was the nature of those new products? Was it related to blood products?
No. So it's a current global trial that's being investigated, and it's a phase. We are involved at the phase 2 stage. Now it's phase 3 of a non-factor replacement product. So rather than factor 8, so we have currently a total of 4 patients who are recruited to that trial, and 2 of whom have received the trial product, which is administered as an injection underneath the skin.
Just a couple of final matters. The inquiry is aware that there may be some patients who feel they've lost trust in their haemophilia centre, and in other parts of the UK they may have changed centre. Given the geographical context of Belfast, what arrangements would be made for any such patients?
So with regards to patients transitioning out or moving, I suppose there's a routine situation for our students and student sharing. If an individual patient is not content with regards to the service that is being provided, then extra contractual referrals or a routine health board provision that patients can be referred to another provider, mostly within the United Kingdom, for ongoing provision of care.
And so in a Belfast context, where would that be to?
It can be left open with regards to the family themselves, but the vast majority, or on the one occasion that has been, that would be to a London centre that the direction was made.
You've discussed your perspective of the impact on patients and families of the infections with HIV and/or hepatitis through blood products. Can you tell us what you've observed in your interactions with these patients and their relatives, of what the impact has been on them?
Yeah, I think that if I go back to 2008 whenever I started, and having met them all and then seeing them now within the lens of the inquiry, I think that the inquiry itself has given them that opportunity, I think, to go back to when the discussions had happened and almost to relive those years. But as an older version of themselves, looking back at the younger version. I think for many years, I think my statement will allude to the wife of a patient who really has summed it up quite significantly, I think, for me, and as with most, it sort of resonates over a long period of time, in that their life has been like a snow globe. And, the snow has laid thick and doesn't move, and everything is all very controlled. And that's the way that they have just left it. So in 2008, there would have been open discussions with regards to, as I am with you now, with the patients, and then to see where they're at. But I think that now, on retrospect and looking back, and with the appropriate attention that's now being given to what has happened in Northern Ireland, that the globe has been shook. And then all of a sudden, the snow itself is working away. So any control or any reminding oneself to suppress a feeling or to suppress a thought has gone, and it's very distressing, and they feel that control is lost, and it's difficult.
You've also said this has had a profound effect on your professional practice. Again, can you expand on that for us?
Yes, I think that as a consultant, whenever you inherit your entire patient cohort, you're very much reflective of the fact that in inheriting this cohort, they didn't start with you. And there are many challenges that have arisen for those patients, and as we'd said at the outset, between mistrust and disengagement, and to try to bring them back on board. I've reflected on many occasions whether or not there's something that I have done or that I have contributed in some way to anybody's care that has not gone as I would have expected it to. And what way can we improve the care or to make it better for individuals? But I just think as my testimony with the skipped and look back, I think as a consultant, I often reflect on being a cul-de-sac, and I think a lot of challenges and problems and the weights of people will come to me, and some of it is very difficult to share, and I think that the need to fix is always so high as a doctor, and there's quite a bit of this that I cannot fix. I can make better, but I can't rub out what has gone before. I remember everybody. I may not have met them all. Some of my older men who aren't with us now would have told me as a junior doctor, and would told me stories of all of these amazing people and what they watched them die, and what they died of. But I think my older men were very clever, because they knew I wouldn't forget. And in some way telling me, these men, I say their name with pride. I'm so proud of them. They did nothing to warrant what happened. And yet, families have been so affected that they've lived many years of not telling anybody what happened to them, as if it's a little secret that they can't get out. And that's eaten away at people to think that they can't share what happened. But it wasn't their fault that they got HIV. They didn't deserve to get HIV. They didn't deserve to die of AIDS. But they did. and I stand on the history of the service and remember them. And every time you inject recombinant factor, you remember why you injected. You remember why that such legs gone through in order to get it. And you can't unforget. And I'm glad that I can't forget. Every time there's an empty seat in the waiting room, I think that could have been him, and I could have had an opportunity to look after, but I didn't. So yeah, I think my career has changed from what little green consultant in 2008 thought I could save the world, and all we can ever do is try to improve on what has gone before. That's what I'll always strive to do.
Thank you. I have no further questions, Dr. Benson. We do need to take a short break so that the recognised legal representatives of core participants can tell us if they have any further questions. So I imagine you may have some questions as well.
I just have two or three, but I'll wait, obviously, till you've garnered whatever questions there may be, and any questions, of course, from those who represent Mr. Benson.
Indeed.
Too. So let's say half an hour, shall we? Would that be long enough, do you think?
I expect so, sir.
Does that give you enough time to have a proper break?
Yes, thank you.
Okay, half an hour, and we'll come back. We'll make it 20 to 12.
Thank you.
To 2, I'm sorry.